Afternoon, everybody. The recording is in progress, in case you didn't know that. So good afternoon, everybody. Thank you for coming to Cardiology, Cardiovascular Medicine Grand Rounds today. And we have a special speaker today who's the first of what we hope will be an annual exchange of Grand Round speakers between here and Stanford. And Dr. Helms will be exchanging in May, going to Stanford to give our talk there. But today we have the pleasure of having Dr. Zhu here with us today. She's an assistant professor of medicine whose clinical and research expertise focuses on cardio-oncology and cardio-immunology. She specializes in the cardiovascular care of patients undergoing therapies for cancer, with a particular focus on the effects of immunotherapies and on the heart. She received a bioengineering degree from MIT, medical degree from Case Western University, and completed clinical cardiology fellowship and internal medicine residency training at Stanford University School of Medicine. Dr. Zhu's laboratory focuses on myocarditis, cardiac inflammation, and the effects of cancer chemotherapy therapeutics on the cardiovascular system. Her current research employs clinical data, biobank samples, and in vivo and vitro preclinical models in combination with single-cell technologies to study immune-based toxicities in the heart. Dr. Zhu's clinic sees cardio-oncology and cardio-immunology patients, and her lab focuses on devising new methods for minimizing cardiovascular complications in the cancer and autoimmune patient populations. So it's a real delight to have Dr. Zhu here, and we look forward to your talk.
Thank you so much. Hi, everyone. Thank you so much for having me. It's really an honor to be here to give this talk. These are my disclosures. So I'm a physician scientist, and my clinical efforts are focused around cardio-oncology, but my laboratory is actually focused on 3 areas. The first is cardio-oncology, and we mostly study immune checkpoint inhibitor myocarditis. The second is actually cardio-immunology, where we've been really diving into cardiac sarcoidosis. And the third area, which is related to the first 2, but also its own separate thing, is the use of high-throughput deep immunophenotyping to discover biomarkers for early disease risk stratification. And so I'll be mostly focusing on our work within cardio-oncology because that's most of the work we've done so far, but we're very excited to be diving into these other 2 areas as well. So for this audience, I don't have to give too much of an introduction, but in terms of what is cardio-oncology, I like to think about it as it's really protecting the heart through cancer therapies and beyond. And so as everyone here knows, the field of oncology has really undergone a huge revolution in the past 2 decades. And this has really been driven by the introduction of targeted therapies. However, heart disease remains a major driver of mortality and morbidity among cancer survivors, and with heart failure actually remaining a leading cause of death in cancer survivors. So when we think of cardio-oncology, we often think of anthracycline cardiotoxicity, which falls under the category of traditional cytotoxic chemotherapies. Traditional cytotoxic chemotherapy broadly targets fast replicating cells. And so you have severe nonspecific side effects like nausea, vomiting, hair loss, and cytopenias. Novel targeted agents in the blue on the right here were introduced onto the scene, like I said, in the past 2 decades, and they're actually targeted to the molecular profile of the tumor. So they're more effective, and they're also more effective oftentimes against more advanced cancers, previously thought to be untreatable. However, we're also entering into a whole new era in cardio-oncology where we're discovering and still figuring out some of the effects of these targeted therapies on the heart, some of which can have quite dramatic consequences on the heart, as we'll see in this talk. As newer targeted cancer agents are introduced onto the market, cardiotoxicity from each new agent often gets recognized after a period of time of use in the real world. This makes prompt recognition, diagnosis, and management of such cardiotoxicities difficult. And so this is oftentimes monitoring guidelines are unclear or absent, and this is an area in need of more prospective data. Immune checkpoint inhibitors, or ICI, are one such class of novel targeted agents. They were introduced in the early 2000s and have really revolutionized cancer therapy. These are drugs that enhance the immune system's ability to kill cancer cells by releasing the brakes on T cell activation against tumors. And this really has changed the game for many late or metastatic cancers in terms of increasing survival. And they're now also increasingly used in early stage cancers. Actually, up to half of all cancer patients now qualify to get this class of drugs. And the number continues to grow each year. So on the right here is a graph that I pulled from the Stanford EMR that shows all the orders of immunotherapy since the early 2000s. And you can see this really exponential growth in orders. And I believe this is a pattern that's also reflected around the world. So normal T cell activation occurs when the T cell receptor on the T cell interacts with the MHC complex on the antigen presenting cell. And this causes a complex series of intracellular signaling to start T cell activation. However, there's normally a secondary inhibitory signal where there's a PD-L1 receptor on the T cell that interacts with a PD-L1 ligand on the antigen presenting cell. And when this signal is present, inhibition of T cell activation occurs, and T cell activation does not normally happen against, let's say, the body's normal cells. So tumor cells have actually learned to hijack this mechanism by also expressing PD-L1 ligand on their surfaces. And therefore, the T cell is inhibited and appropriate T cell activation does not occur against the tumor cell. And therefore, the tumor cells are actually able to evade the immune system in this way. In the setting of immune checkpoint inhibitors, such as anti-PD-1 or anti-PD-L1, these are monoclonal antibodies against these checkpoints. And so when these checkpoints are inhibited, the secondary inhibition signal does not occur. And so the T cell is able to proceed and be activated appropriately against the tumor cell. And this is how T cells get reinvigorated to attack tumor cells. However, you can see a situation where the treatment with these monoclonal antibodies may lead to autoimmunity. And there's now a number of these immune checkpoint inhibitors on the market that includes anti-CTLA-4, anti-LAG-3, anti-PD-1, and anti-PD-L1, but they all work by similar mechanisms. Unfortunately, ICI myocarditis is a feared complication from ICI, which happens in about 1% of patients receiving ICI, but in fulminant cases can still have quite a high case fatality rate. In the early days, up to 50% of patients presenting with this disease. Patients typically present with, in severe cases, with heart failure, ventricular arrhythmias, complete heart block. And in this paper that was published in New England Journal of Medicine by Johnson et al., the two patients went on, unfortunately, to have autopsy that showed that their hearts were full of T cells and macrophages that was invading the myocardium and also invading the conduction system. So for patients who are diagnosed with ICI myocarditis, glucocorticoids remain the first line of therapy, despite being non-targeted and having limited efficacy. But oftentimes we start something like Solumedrol 1 gram daily for 3 to 5 days. And this works in a lot of cases, but not all cases. And non-targeted therapies like glucocorticoids can have side effects as well. So the ultimate goal is to get these patients on more targeted therapies that are specific to the mechanism of ICI myocarditis. And this will hopefully have more efficacy and also limit side effects. However, anything that we use to target ICI myocarditis must also allow normal T cell activation to occur against the tumor. And so this often presents a type of conundrum. So I've been lucky to found and direct this translational cardio-oncology program at Stanford, in which we have a 3-pronged mission. So the clinical program was actually there before I joined. It was started by Ron Watelis, And essentially, it's a collaborative, multidisciplinary program that's focused on providing the entire spectrum of care to cardiovascular care to cancer patients. So there's a dedicated outpatient clinic, and there's also inpatient consultation liaisoning. There's also education that's built in, so residents and fellows rotate through the cardio-oncology clinic, and we also have monthly cardio-onc seminars. The research aspect has been an important mission that I've been excited to grow. And we do have sort of three-pronged approach to clinical, translational, and basic research addressing problems in the area of cardiotoxicity in patients. And the approach that we have taken is to biobank samples from patients with cardio-oncologic and cardio-immunologic diseases. So taking the example of ICI myocarditis, we'll biobank peripheral blood, so PBMCs from patients, heart biopsy samples or autopsy samples if available, and tumor samples as well. Then we perform high throughput deep immunophenotyping with a multi-pronged approach that includes single-cell RNA sequencing, single-cell TCR sequencing, site-seq, that is protein immunophenotyping, as well as mass cytometry or CyTOF. A lot of these technologies can be challenging to do in high throughput, mostly because of time and cost issues. So my lab has optimized a couple of pipelines to do this in high throughput. So we use the 10x Genomics 5' pipeline and do all our own library prep in-house, which actually saves a lot on time and cost. We use a homegrown sample multiplexing pipeline that uses antibodies such as CD45 and beta-2 microglobulin, where we hashtag samples ahead of time and then multiplex them on the same gel bead. So we're actually able to do up to 8 samples per gel bead, which significantly cuts down on cost of this technology. And last but not least, we also do all our own bioinformatics in-house, and that really allows for maximal versatility in data extraction and analysis. In addition to single-cell RNA-seq, we also do single-cell TCR sequencing. And so this is actually sequencing the VDJ region of the T-cell receptor that allows us to uniquely ID each T-cell clone in a tissue sample. So we also created our own bioinformatic pipeline to analyze the data. So for example, on the right, this top here is a UMAP of all the CD8 T cells from the blood of patients with ICI myocarditis in a cohort from our biobank. And we're able to overlay the unique T-cell TCR clones on top of the UMAP so we can see which of these T cells are clonally expanded while also maintaining their transcriptomic signatures. And so group A here are a group of patients who received ICIs and had no known autoimmunity. Group B are patients who received ICI and have a non-cardiac IRAE, such as hepatitis or thyroiditis or pneumonitis, but nothing cardiac. And then group C are patients with ICI myocarditis. And you can see that in the group C patients, they have this significant clonal T cell expansion in this area that we have labeled the TEMRA CD8 T cells. And these are long-living sort of effector-like CD8 T cells that are actually often implicated in autoimmunity. We're also able to actually lineage trace these T cells over time. So we have from the same patient an early time point and a late time point sample where upon diagnosis, the patient had blood drawn. And you can see most of the clonally expanded T cells, and each individual color here represents an individual unique T cell clone. They're actually all clustered here in this TEMRA CD8 area. But in the late time point, they actually have now migrated over to more of a central memory phenotype. We're also able to pull out the unique transcriptomic signatures of each of these T cell clones. And we can see that things like autoimmune genes like KLRK1 are really high up in the early time point. And in the late time point, this is after a full course of steroids, the expression of KLRK1 has gone down. And exhaustion markers like LAG3 have gone up. So this is just an example of something that we can do while pairing single-cell TCR-seq with single-cell RNA-seq. We also do CyTOF protein immunophenotyping using up to 56 cell surface intracellular markers. So this is, we have antibodies that are labeled with elemental isotopes, And like flow cytometry, where you have antibodies that are labeled with fluorescent markers, you can essentially measure what the cell expresses by mass. It's driven through a nebulizer and analyzed. And what this allows us to do is really finely phenotype cells on a protein level. And what we did also was create our own bioinformatic pipeline where we were able to take the CyTOF data and convert it into a format that looks a lot like RNA-seq data. So we can put the cells and label them by their canonical markers on a UMAP, just the same way you would do RNA-seq data, and get these really nice finely expressed clusters. And last but not least, we also do site-seq, which is also simultaneous protein immunophenotyping. So the advantage of this over CyTOF is that you can actually do this in the same sample as the RNA-seq sample. So if you have just one sample, you can do simultaneous RNA-seq, TCR-seq, and site-seq, and get simultaneous RNA, T-cell, and protein level data. So this is really powerful, especially for certain populations of immune cells, because things that you would think are obvious on an RNA level, such as expression of CD4, are actually not quite well expressed on the RNA level. So having that protein data is actually quite helpful to increase the resolution. And so using these technologies, we were the first group to identify major cytotoxic CD8 T-cell subsets in the blood of patients with immune checkpoint inhibitor myocarditis. This was work published in Circulation when I was in the lab of my mentor, Sean Wu. And what we found was we basically hypothesized that ICI myocarditis is caused by activation and clonal expansion of CD8 T cells that are actually activated against a specific cardiac autoantigen. And this leads to cardiac inflammation. Oops. Sorry. So to address this, we used both mouse and human samples, and we isolated immune cells from the blood and hearts of mice, as well as the blood of patients and heart when available. And we did our multi-omics pipeline to discover culprit cell subsets and molecular pathways. And we used several mouse models in our work, but this was really the first model that got us off the ground. So this is a genetic PD-1 knockout. These mice get quite sick by 4 weeks of age. So at 2 weeks, you can see on top wild type, on the bottom is the knockout. They're actually quite similar to the wild type cohorts. By 3 weeks, they start to have early immune infiltrates. And by 4 weeks, they're quite infiltrated and sick. Echocardiogram, only 50% of the mice have significant LV drop, and this is actually quite consistent with the patient as well. So this is actually a mouse echo that I did of a mouse that actually developed cardiac arrest after looking at histology, had quite severe lymphocytic infiltration. Echo, they look like they just kind of have a subtle LVEF drop at the same time. So using this mouse model and using patient samples, we were able to find that in ICI myocarditis mice, they actually had a significant clonal expansion of these effector memory CD8 T cells that we think correlate with this TEMRA CD8 population that we see in humans. And we were able to confirm using this multimodal approach in the human samples that this correlated as well with the TEMRA CD8 population. This is patient biopsy sample showing that these activated CD8 T cells are also in the myocardium. And this is time point data where this patient presented with ICI myocarditis with a troponin of over 10,000 nanograms per liter. He underwent a full course of steroids. And on day 65, this was his troponin, so it had dropped down to 0. We drew his blood again. On MRI, he had a delayed gadolinium enhancement in the lateral ventricle, left ventricle, and then also had T2 enhancement consistent with myocardial edema. And in the late time point, the late gadolinium enhancement was still there. The T2 edema was slightly better. But interestingly, on the T cell sequencing, in the early time point, up to 50%, 47% of his peripheral T cells were actually clonally expanded, which is actually quite a striking finding because if you take a normal healthy person's heart, you expect maybe a normal healthy person's blood, you would expect to see maybe 3 to 5% of the T cells are expanded. So this is quite a striking finding. This 9.3% is just one T cell clone. So that alone is quite striking. After a full course of steroids, actually the T cell clones have contracted somewhat, but not completely gone away. So this is actually consistent with this clinical observation that, if you start somebody on an immune checkpoint inhibitor, they're actually going to get the tumor killing benefits of this immune checkpoint inhibitor for potentially years after. And also they are at risk for autoimmunity, also potentially years after, although the incidence is lower. And so since that paper came out, there has been additional mechanistic progress in the field. So Maggie Axelrod, Justin Balco, and Javed Moslehi showed that an alpha myosin heavy chain peptide is actually one of the antigen driving expansion of these CD8 T cells. Taijun Wang and Daniela Chiakova also showed this in a different mouse model. And then Corey Levine's group then showed that some of these CD8 T cells secrete interferon gamma and signal to interferon gamma specific macrophages, and that inhibiting interferon gamma actually improves survival in these mice. So today I'm excited to share a story from my lab that was actually just published in Circulation Research this Tuesday, in which we focus on a novel target, CXCR3, to treat ICI myocarditis. And this is a pathway that is downstream of these interferon gamma responsive macrophages. So to start, we wanted to get a global picture of the origin of ICI myocarditis. So we took our genetic PD-1 knockout mice and we did serial single-cell RNA-seq and TCR-seq on time points 1, 2, and 4 weeks of age. And what we saw was that cytotoxic CD8 T cells expressing high levels of the chemokine receptor CXCR3 actually enter the heart at 2 weeks of age. So on the top is wild type, on the bottom is the knockout. So in the blue is the population we're looking at. So actually, even before the clinical phenotype manifests at 2 weeks, they're already present. And shown here in the purple dots is the TCR clonal expansion. So these are actually a clonally expanded T cell population, suggesting that they're reacting to some kind of antigen. And if you look at their gene expression profile, they're expressing high cytotoxicity markers like granzyme and perforin. So in addition, we also saw infiltration of macrophages quite early as well. So at 2 weeks of age, again, prior to clinical onset of myocarditis, there were CCR2 bone marrow-derived macrophages that also enter the heart here in the red population. And interestingly, these macrophages also express high levels of the recruiting chemokine CXCL9 and 10. So to determine the significance of these CCR2 positive macrophages in ICI myocarditis, we took to ablating macrophages from mice. So we used a new model where we took our genetic model and we treated with liposomal clonidinate versus liposomal control. We were able to deplete macrophages, and we actually saw a significantly improvement in survival and reduce inflammatory infiltrates in the heart and reduce cardiomyocyte apoptosis in the mice that had macrophages depleted. Furthermore, macrophage depletion was associated with reduced frequency of CXCR3 high CD8 T cells in the heart, implying that the presence of the macrophages play at least a partial contributing role to the presence of the CXCR3 high CD8 T cells in the heart. So taking a step back, what are the druggable targets in ICI myocarditis? Well, we think there's a primordial priming event of T cells that are priming against cardiac antigens. So that are being presented. So these T cells probably have antigens presented to them by antigen presenting cells in secondary lymphoid organs. These T cells probably have escaped some thymic selection and they're primed to attack the heart, but they're normally inhibited in the setting of just having normal peripheral tolerance and no ICI. Then you give the ICI and you have release of this T cell checkpoint. And now these T cells begin to activate and clonally expand. And this can happen in the blood as well as the heart. And this was shown by our work in circulation. These T cells are then primed to enter the heart, and they undergo early release of cytokines such as interferon gamma. And this recruits monocyte-derived macrophages, which start to express interferon gamma response elements and activating JAK-STAT pathway. And these recruited macrophages then enter the heart and begin to express CXCL9 and 10. This then interacts with CXCR3 on more effector CD8 T cells. These enter the heart, and this begins this positive feedback loop of cytotoxicity. And so we decided to focus actually on this last step in terms of a therapeutic strategy. We also wanted to make sure this target was translationally relevant, so we checked in the hearts of patients with ICI myocarditis. And here you can see 3 cases. And indeed, we saw that in all patients that we had with ICI myocarditis, they expressed high levels of CXCR3 positive CD8 T cells and CXCL9 and 10 positive macrophages. So we treated mice so we wanted a more drug-inducible model rather than the genetic model, because these genetic mice, again, are very sick early on, and it's hard to time the myocarditis. So we moved to a drug-treated model where we took MRL wild-type mice, then we treat them with anti-PD-1, anti-CTLA-4 immunotherapy, just like patients would in receiving dual immunotherapy. So they would receive doses twice a week, up to 6 doses. We would also characterize their plasma troponin levels, just like we would in patients. And you see there is a rise in troponin in the treated mice with immunotherapy compared to IgG control. And then additionally, we would then treat these mice with anti-CXCR3 blocking antibody versus IgG control to see if we could then rescue and mitigate the myocarditis phenotype. And what we saw was a significant reduction in the plasma troponin level in the mice that had received the anti-CXCR3 blocking antibodies. We also saw a significant improvement histologically in reduced immune infiltration. This troponin T stain just shows, preserved cardiomyocyte integrity, and then caspase-3 shows reduced apoptosis. And quantification confirmed this, and also most importantly, the mice survived if they're treated with anti-CXCR3. We wanted to understand how blocking CXCR3 was actually reducing myocarditis. And so we had this hypothesis that it was the CCR2 macrophages that was recruiting these T cells. So we moved to this Transwell assay where we plated these effector CD8 T cells from these ICIM mice in this upper well. This is a porous membrane here. And then down here, we plated CCR2 macrophages. And then we measured the number of activated T cells that arrive here in the bottom well. What we saw was that CXCR3 blockade significantly, so first of all, if you have no macrophages down here, the T cells don't migrate. If you put macrophages down here, lots of T cells migrate. And if you block CXCR3, fewer T cells migrate. And this actually also occurs if you block CXCL9 and 10, which are the ligands. And then actually, if you remove macrophages and you put just the ligands, you also get migration. And so these set of experiments also supported the idea that there is recruitment of the CXCR3 positive CD8 T cells by the macrophages. And these are cells actually isolated from the hearts of immune checkpoint inhibitor myocarditis mice. So really kind of confirming that it's consistent with the disease. Additionally, we also did functional assays. So we asked the question, are these CXCR3 CD8 T cells actually directly cytotoxic to the cardiomyocytes? So what we did was we did background match neonatal cardiomyocytes with T cells that were isolated from the MRL PD-1 knockout mice. We co-cultured them, and then we measured apoptosis. So we used early apoptosis measurement with alpha phosphatidylserine, and then propydium iodide as a late apoptosis marker. And then we saw that actually cardiomyocytes that had been co-cultured with the CD8 T cells actually did significantly have increased apoptosis. Lastly, we sought to determine the downstream effects of CXCL9 and 10 binding to the CXCR3 T cells. We found upregulation of the pathways of phospho-ERK and P65, and interestingly, increased expression of ITGA4, which encodes for this CD49D, which is the alpha subunit of the integrant VLA4, which is actually important for T cell migration and activation. So this all fits. So putting it all together, we think that, so what we investigated here is upon treatment with immune checkpoint inhibitors, the T cells activate, they secrete cytokines, the macrophages enter the heart, they recruit additional CXCR3 positive CD8 T cells that express integrins that help them migrate into the heart. And ultimately, they are the main players in killing cardiomyocytes in this type of myocarditis. And I would suspect, too, that there may be some commonalities with this type of myocarditis with other types of myocarditis, like viral and other autoimmune type myocarditis. So we're pretty excited about the implications of this finding. And so, the elephant in the room is any therapy that you're using to treat myocarditis due to immune checkpoint inhibitors, you want to make sure that they're not also reducing the efficacy of immune checkpoint inhibitors against the tumor. And so what we did was we developed another mouse model where we inoculated these mice with tumor cells, such as B16F1 melanoma. There's also MC38 colorectal cells. These are two cancers where immunotherapy is pretty commonly used. And so these mice grow tumors, and then we treat them with ICI, and we see a tumor reduction. They also develop myocarditis. And the goal is to evaluate if you actually then treat these mice with anti-CXCL9 and 10 or CXCR3, if you also see a reduction in efficacy of the ICI. And actually, we have some exciting preliminary results that it does not seem to affect it. So we're pretty excited about that. So more work to come in that area. There's also this paper that was just out in Nature from Chloe Villani, Carrie Reynolds, and Tom Nealon's group at MGH. So they did paired single-cell multiomics on heart, tumor, and blood of ICI myocarditis patients. And they found a cluster of CXCR3 high cycling T cells, CD8 T cells associated with fatal cases of ICI myocarditis, which is pretty exciting because it really confirms what we found in our mice and our human blood samples as well. And interestingly, they show that these CXCR3 high CD8 T cells actually don't share any expanded TCRs with T cells in tumor. So actually, this suggests that there, at least in these samples, there's different repertoires of antigen that are driving specific T cell expansion in heart versus tumor. So we're now seeking to test some pathways in new human models. So we have used some samples from our biobank and reprogrammed into iPSCs, induced pluripotent stem cells, and differentiated to cardiomyocytes. And we're testing this co-culture model where we're adding patient-specific CD8 T cells to try to measure cytotoxicity of these T cells against the patient's own cardiomyocytes, and then interfering that with specific disruptions in the pathway. And I had mentioned at the beginning, we're also interested in studying cardiac sarcoid. So this is a model that can also be applied to study cardiac sarcoid. So going back to this vision of the ICI myocarditis treatment, we are now having an increasing growing toolkit of therapeutic drugs that can bring us closer to being able to focus on just using targeted therapies and avoiding side effects of steroids. And these therapies hopefully would be safe to use from a tumor control standpoint. And I'll just mention briefly that we are now seeking to apply all these tools and insights that we gained in ICI myocarditis to cardiac sarcoid, another devastating immune-based disease in the heart. We were initially lucky to be funded by some private patient funding to get off the ground. And then my lab recently received a CATS R01 to study this work. So really excited to really dive into that. And we are seeking to approach this problem in a similar manner, which we start with an unbiased multi-omics approach, find some molecular targets and pathway, test this mechanistically in our models, and then hopefully bring it back to patients in terms of trials and targeted therapeutics. And lastly, I'll spend the last few minutes talking about our focused biomarker discovery efforts. And so this is a CTCAE grading criteria for different levels of severity for ICI cardiotoxicity. And so as you probably know, a lot of patients present. So grade 1 is sort of just abnormal biomarkers, no symptoms. Grade 2 is mild symptoms and abnormal biomarkers and maybe some EKG findings. Grade 1 can also have that. Grade 3 is where a lot of patients present because you have a wall motion abnormality. You also have cardiac MRI that could be positive at this point. And then grade 4 is when they're really sick, they're in the ICU, they need mechanical support. And grade 5 is death. So if you allow patients to brew for a long time, we do know that the immune system sort of ramps up and has this positive feedback loop. So our hope was to try to intercept and identify more patients in the grade 1 and 2 range somehow and sort of avoid a late presentation. And so what we did, and this was a paper published by Sarah Waliani, who's an intern I worked with back in 2021. And we did this pilot project where we started troponin monitoring in all patients with that were receiving ICI at Stanford. And so this was a project involving the initial 214 patients. And basically, this was an initial feasibility proof of concept type study. What we found was that 11% of patients receiving immunotherapy had an elevated troponin. And the actual rate of myocarditis remained at about 1.4%. However, 2 out of the 3 myocarditis cases were actually asymptomatic or minimally symptomatic despite a troponin ranging from 4,000 to 11,000. And they actually did have wall motion abnormalities and MRI findings. The positive predictive value was low if you use the standard troponin cutoff of 55 nanograms per liter. It was only 12.5%. If you increase the cutoff to 1,000, the positive predictive value increased to 75%. And if you further increase the threshold to 2,000, then it was 100%. So this suggested that there are likely different thresholds that are needed for these patients versus your classic 99th percentile cutoff of 55 nanograms per liter. And I also will mention all of this was done with this rapid cardio-oncology triage team and a pager that I, at the time, and now my team cover every time there's a positive troponin. And we kind of figure out how to triage these patients and avoid unnecessary ER visits. So now we have a larger cohort of 400 plus patients that we just finished analyzing and are working to publish. Evelyn Chen is a cardiology fellow in my lab who just received her F32 to actually combine troponin with single-cell RNA-seq and multi-omics to determine whether novel T-cell markers can actually better predict who's going to develop fulminant myocarditis. And this is in combination with troponin patterns. So we think that patients with a rapidly elevating acute troponin elevation that is very high obviously are going to be higher risk compared to patients who are smoldering with a subacute presentation. So really excited about this, and we'll see. And then this is an example of an early protocol that we used and how to respond to these positive troponins. So this was, I think, relatively earlier days because we used a very conservative threshold of 100 nanograms per liter. So basically, if the patient has positive troponin, they would be, and if they had a troponin that was higher than 100, regardless of symptoms, they would get additional workup like EKG, echo, and we would see them in clinic, and then we may do additional workup like MRI, CCTA, and possibly biopsy, just depends. If they're less than 100 and asymptomatic, we actually largely continue monitoring and sort of wait for them to present themselves. And then if they're under 100 and symptomatic, then they get further workup regardless. And now with the additional patient, the larger cohort, we find that probably the threshold is a little higher, something like 243. And this is a threshold where you have maybe more optimal sensitivity and specificity. So going to incorporate this vision of biomarkers in ICI myocarditis, the idea is that you could identify patients who are at high risk with a high-risk troponin and a high-risk immune profile and be able to act on those patients quickly. And then for the lower risk patients, lower risk troponin or favorable immune profile, you can just let them continue to get their immunotherapy and not have any interruptions in treatment. And so with that, I'd like to thank all the people in my lab who have done the really hard work. Also like to thank my mentors, Sean Wu, who is my postdoctoral mentor, Joe Wu, Ron Watellis, my clinical mentor, and Tony Rosenzweig, who is my Sarnoff mentor and who's been a great career mentor over the years. And then my family, my husband and my two boys, Bryce, who's 3 years old, and Dean, who's 8 months old, and they're having fun playing in the snow right now. So. All right, and that, thank you so much, and take questions.
So thank you very much. That was a fantastic talk. I'm just going to put it out there that I am not volunteering. Dr. Fetcher and I were just chuckling from our melanoma colleague right there, because I'm not volunteering for the positive troponin with ICI myocarditis. Just throwing that out there right now. With that being said, questions from the audience? Yes, Dr. Eagle.
I loved your talk. It was superb.
Thank you.
What about identifying the patients before they get the chemotherapy? Is there a way of genetic or proteomic profiling to find out who's vulnerable instead of waiting for injury?
Yeah, I think certainly, most certainly, there's something there. So the part that I also should have mentioned is that in that Nature paper where they identified the alpha myosin heavy chain peptide as one of the antigens, they also did find a correlation with HLA type. And so we think that there are certain HLA types that are higher risk. The only issue is we're still dealing with relatively smaller sample sizes. And so I think to validate that and really kind of make that prime time still will be some work. But I think that would be great. The only issue is though that so in that study, those patients, some of those patients, for instance, they had the HLA type and they also had alpha MHC specific T cells, but they don't develop the disease. So we think that there are probably higher risk, but there's probably, additional things that need to happen, maybe macrophage crosstalk and this perfect storm. Yeah. Mm-hmm.
Dr. Pinsky.
I have to concur. It was a fabulous talk.
Thank you.
In my early years, I worked with Dr. Sushi Foka at Columbia, and she discovered the anti-idiotype antibody response. And it's a way to tamp down where you develop an antibody to an antigen to an antibody, and it's sort of this network. It sort of tones things down. Is there a way, because the antigen or likely antigen culprits in ICI myocarditis have been identified, that we could then put in anti-idiotype T cells to tamp down that specific clonal expansion?
Yeah, no, I think that's a great thought. I'm sure someone's working on it, but no, right now I'm not aware that of any projects. But we have thought about how to make use of the idea that we know that both the T cell side that are reacting to that antigen and the actual antigen. Likely, there's also other antigens. So this is definitely one of the main ones. But so first of all, I think you might cover a large portion of the disease. You may not cover all. But yeah, we have a few grant applications. So we'll see. Yeah, definitely. I think that's very interesting.
Wonderful talk. Thanks. So it sounds like your data already from the preclinical models, it's very compelling that this would benefit these patients. But then there's going to be, I would imagine, quite big regulatory hurdles because you're going to be proposing that these are co-treatments with medications that have been already past regulatory hurdles for cancer efficacy. And so like, what do you think it's going to be like to get something like this past regulatory hurdles? Would it need, because you would have to deal with this issue of even though your data suggests that the tumors may still respond, in humans it could be different. And would you need like tumor biopsies from patients, some kind of profiling, or how can you get to this to the clinic?
Yeah, no, definitely. I think there's still a long road ahead in terms of actually translating this to the clinic. And, we haven't even mentioned like large animal models. And so there's definitely many steps ahead. The other thought is, whether or not there could be some repurposing of existing drugs. But let's say we are starting with a new molecule, then yes, there's going to be many hurdles ahead to address all of that. We are doing tumor profiling as well from humans. So that's a first step. Yeah.
It's just so interesting. I got another question, clinical side of the universe. So because the antigens, which seem to be recognized, are intracellular, is there anything we can do to reduce our intracellular exposure to these antigens? So for instance, should we tell our patients during chemotherapy, don't exercise? Should we massively beta block them? Is there something we can do so that they don't reveal the antigens to these marauding T cells?
Yeah, so and there's one key piece of data that we're missing before we try all of that, and that's really pre-immunotherapy profiling in patients who later on develop ICI myocarditis versus those who later on don't develop anything, because all of the profiling that we're doing starts with already a positive troponin. So at that point, assuming they're already primed, but the key question and the trouble with baseline blood, and this is something we're working on, is you really have to capture a much larger population of patients to really get one ICI myocarditis case prospectively. And then retrospectively, you just have to be lucky that somebody drew that blood before that patient developed ICI myocarditis. But I think it would be important to know if, even before immunotherapy, I think a lot of patients are already walking around with alpha MHC T cells, and there's not a problem. And who knows when those T cells were primed. So the problem with this, and I think it potentially could be a strategy, but then what if they already have those T cells and we're doing all of this and it was already there to begin with, but we don't know that. Yeah.
I'm not sure to get the chat questions. Are there? There's no chat question. So, we see a lot of the smoldering myocarditis, and our practice is pretty much the same thing. We slowly reintroduce this, but you mentioned that they have memory, like you have autoimmune stuff down the line. What are your thoughts on management down the line in terms of imaging and keeping an eye on these patients?
Yeah. I mean, I think most of us, and yourself included, when we see these patients, most of the really bad cases actually do seem to happen within that first 2 to 3 month period. However, I think we probably also all have seen cases where a year after stopping immunotherapy, or we published on a case where it was like 2+ years after stopping immunotherapy, the patient presented with fulminant myocarditis. So, it's hard to know because there's so many patients that get immunotherapy. We currently stop trending troponins when they stop immunotherapy. Mm-hmm. So there's no monitoring after that. And I think it's still unclear to me if there's enough of those patients that present late. I guess there's always a risk, but then it's just balancing how many patients you're going to trend troponins in forever. Mm-hmm. Yeah.
Well, thank you so much. Really good.
Thank you.